who do you need to select into your DMOAD trial to get your drug approved? And so I think that the question is what is the question? What are we trying to predict?
And combining them. But if we think of all the rest of the discussions today, isn't it counterintuitive? Because you are selecting one that is progressing because of A and B and C and lumping all comers into one box. Shouldn't we be looking at fewer combinations of biomarkers so we have the endotype-driven progression rather than again lumping them into all boxes?
Yeah, I think a question that statisticians love to ask is, what is the question? What are we trying to do? And if in order to get your DMOAD approved, you need to show that it slows progression of X-ray based joint space width and that it alleviates symptoms, then the patient that you want to identify for your trial is somebody who is at high risk of those outcomes. I think the question of, is that a relevant outcome to predict, or is it even reasonable to lump everybody together who is progressing by 0.7 of a millimeter of joint space width, some of whom are doing so because of meniscal extrusion, some of whom are doing so because of cartilage loss, some of whom are, men who are 6.5 feet tall, where 0.7 of a millimeter isn't actually that much progression. Should we be lumping all of those people together? I think is a great question, but it's kind of a different question than who do you need to select into your DMOAD trial to get your drug approved? And so I think that the question is what is the question? What are we trying to predict?
Yeah, fair enough. I'm just worried that we are not targeting patients. David Felson has written the straight to the point David Felson question here. So how can you use post-baseline biomarker data in a trial when you select trial participants for randomization at baseline? I think that's an evil question. Yeah,
that's a great question. And we've sort of mulled this over some. I mean, I think what's interesting, and we heard earlier about the approach study, which is, utilizing data from an existing cohort and then sort of enrolling those subjects into the next phase of the trial. So, I suppose if you had a setup like that where you were, enrolling subjects into the OAI or to a similar cohort study where you had that data available. And, I wish I could remember, maybe somebody remembers, I think it was the ACR meeting a few years ago. There was a group that actually tried to do like an economic analysis that said, how good would we have to do in our enrichment strategy in order for it to make sense to sort of screen people at baseline and at 12 months? And I think they determined that really wouldn't be feasible. You would have to have a pretty perfect algorithm to do that. So yeah, I'm not sure that looking at these short-term changes to predict longer-term progression is really relevant in terms of an enrichment strategy. I just think unless we had really, really cheap biomarkers, that wouldn't work. But thinking about surrogate endpoints and, could we, instead of looking at joint space width over 4 years or over 6 years, could we look at change in cartilage thickness in the central medial femur over 12 months or over 24 months. And so I think that was more of the rationale for including those short-term changes predicting long-term progression. But I agree. I don't think that financially it is really feasible to try to consider an enrichment strategy where you're measuring biomarkers over 24 months before you even randomize.
David, do you want to?
Yeah, I'm a little bit concerned. Number one, I think it's elegant, analytic, and statistical work, Jaime. You should be congratulated.
Thank you.
And I'm nervous that, assuming that all we have is baseline data before we randomize people in trials, which is what the relevant situation is, that the data you've shown, which is quite comprehensive, just doesn't generate a substantial enough identification of those at progression to make it worth our while. And I'm wondering why we keep pursuing this question, to be honest with you. I realize that's a tough thing to say, but you're going to mess around with a lot of more sophisticated analytic techniques. And the great likelihood is that they're not going to crank up the AUC very much.
Yeah.
And I think we're going to be stuck with baseline predictors of systemic biomarkers for localized disease that just aren't very good. And I'm sort of wondering why we keep going down this road.
I think this brings us back to the phenotype discussion, which Dr. Karsdal, asked about, which we heard about earlier. And the question is, if we're pursuing this enrichment strategy, are we trying to enrich for anybody who is losing 0.7 of a millimeter of joint space, or should we be thinking more about these phenotypes and trying to sort of cluster patients together based on, and we can do it, in anything based on structure, based on pain. There's been a lot of work that Tuhina has done recently with pain phenotypes. Should we be trying to come up with more homogeneous subgroups before we think about doing this enrichment? And I think that's some combination of those is something that we want to think about, because I think that you're right that if this truly is this heterogeneous disease where everybody is kind of progressing for different reasons, progressing on different pathways, are we ever going to come up with a strategy where we can predict that with high accuracy? And I don't think anything has yet.
Thank you for those answers. So we have another question here, and then after that, we're going to look back to David. From Amanda Ali, great presentation. Aside from maintaining power.
Oh, I think you're still muted.
Oh, I hope not. Can you hear what I'm saying?
I can hear you, Morten.
Oh yeah. So hopefully you can hear me. So a presentation from Amanda, or a question from Amanda Ali. Great presentation. Aside from maintaining power, why not only use no progression as controls to maximize discrimination? Wouldn't including joint space with progression only or pain progression only among the controls dilute the effects?
Yes, we've had a lot of debate about this. I think, again, trying to think maybe a little bit more pragmatically, if you're pursuing an enrichment strategy for a clinical trial, you don't get to only test people that are going to have composite progression or no progression. You have to evaluate all comers. And so I think sort of throwing out those people who only had joint space with progression or who only had pain progression, you couldn't sort of do that in a real world setting. You'd have to evaluate everybody sort of who's eligible. And so, I get that again, we've had lots of debates and arguments about this, that what does it mean to sort of predict composite joint space width and pain progression when you have people who are progressing in both of those in your control group? But at the end of the day, if we're talking about trying to do, an enrichment strategy for a clinical trial to identify those people who are likely to progress on both, you have to compare them to everybody else. I think the question might be, maybe we should be looking at predicting people who have progression on any domain versus people who didn't progress at all, versus looking at our sort of composite progressors versus everybody else. And maybe that would be sort of a better enrichment strategy. But I think, that looking at no progression at all versus composite progression is not something that I think sort of lends itself to a real world strategy.
So I appreciate those comments. So if going back to David, I think a professional disagree. Of course, we are able to measure something smart in a systemic fluid to predict progressors, but I think there's one important point. It needs to be an overarching endotype. And I actually think the UK Biobank paper showed that there is this low repair endotype, or at least genes that are associated with repair mechanisms. So possibly we are able to find some of those overarching endotypes, not not that are locally driven because of an event, but simply because of genetic endotypes, overarching endotypes that result in low cartilage formation, for example. So if I'm allowed to ask you a question, David, can you be a little bit more optimistic? You're muted.
Yeah, I'm now not muted, Morten. Thanks for the question. I guess the proof is in the data analysis. I think you gotta demonstrate it. It sounds very promising, but there's a lot of things historically now that have sounded very promising and that have turned out to be, what Jaime showed, and she did it elegantly, which is they don't predict much better than chance. So I think the idea is very appealing, but we need to see some longitudinal data showing that if you measure that phenotype and characterize it well, that it will predict those things that you hope it'll predict.
Yeah, I appreciate that.
And this has been true, not just in this FNIH cohort, but I and others, probably some who are at the meeting, have looked at trajectories of joint space loss, trajectories of cartilage loss, and then have attempted to predict those within the OAI, I think within the Czech cohort. And there's not really been anything that's had AUCs above 0.7, 0.75. So it's not just this biomarkers consortium. It's really been any effort to predict even just structural worsening. So I think it goes back to that question that we're talking about today of phenotypes and should we be even lumping all of these people together, because any way we've tried to analyze it hasn't, we haven't had a high rate of success.
I think we have some members of the Approach Consortium present, actually, and I think, Erwin, you are a member of the Approach Consortium, isn't that right? How is the Approach Consortium dealing with this, first of all, low AUC and combination of markers as compared to using more single markers?
I think approach is more of an academic exercise. So to see if we are even able to find phenotypes, distinguish them, more than to be able to translate them directly into very practical things like selecting subjects for a trial. As I also explained in my presentation, I think the approach is so extensive that it's not practically feasible to do it in many other settings. I think it will not be very easy to translate any results from approach directly to a next trial, but that it will be an achievement in itself if we are able to at least demonstrate that there are different phenotypes at all.
Appreciate that, Edmund. I think we are almost running out of time here before we need to transition into the next session with video presentation.